Hello everyone, and welcome to this open hand webinar, brought to you in association with the University of the Witwatersrand and the South African Society of Hand Therapists. My name is Nicola, and I will be your host. The topic for today's webinar is Keep Your Focus on Function, using the right activities to get your hand injury patients back to daily life. There will be two 20 to 30 minute presentations, followed by time for questions. You can also post your questions in the chat box throughout the presentations, and where possible, we will answer them as they come up. If you have any questions about this or about anything else, then you can send us an email and we will get back to you. For now, it is time to start our webinar. So our first presenter for this evening is Ilande Vorster. Ilande completed her OT degree in 2007. She then obtained her postgraduate diploma in hand therapy, and after that went to complete a master's in occupational therapy, focusing on occupation-based hand therapy. Ilande has worked as a clinician in South Africa and abroad, and has experience in both the public and private sectors. She currently works in private practice in Cape Town, while also lecturing and supervising students for the University of Cape Town and Stellenbosch University. She has presented a number of courses and workshops, and has published within the field of hand therapy. Ilande combines a sound biomechanical approach with a holistic occupation-centered approach, and we're very grateful for her willingness to share this approach with us this evening. Thank you, Ilande.
Hi, good evening, everyone. It's really great to be here, and I just want to thank you, everyone that's organized this for the opportunity. Occupation-based hand therapy is very much a passion of mine, and I think it was born out of kind of getting to a point in my career where I felt like what I was doing wasn't really being an occupational therapist, and this kind of started me thinking about what does it mean to be an OT, specifically working in hand therapy. So that's kind of what my talk is going to focus on today. Right, so for you, those of you that aren't OTs, this is very much coming from an occupational therapy point of view, so if there are any questions, please let us know. I'm going to share my screen so long. Let's get that on. And then I'll just do that. Okay, so there we go. We're just going to have a look at basically where does OT fit into hand therapy, and then also identify key aspects, what is the difference between the biomedical approach, and then how does this change when we're thinking about an occupation-based approach. Looking at the benefits of this, and then how do we actually incorporate it into it. And then at the end, I'll add some quick case studies or case study examples. I'm going to go through this quite quickly, so please stop me if there's anything that's unclear, or if I need to hurry up or slow down, but I'm going to get started. All right, so just a reminder for those of us that are occupational therapists, we essentially are experts at function. I know some of us probably don't feel like experts maybe if you're at the start of your career, but essentially occupational therapy really is that we are the ones that look at function, which means we're also experts at activity analysis. We believe that participating in occupations promote health, they promote well-being. We believe in the restorative power of occupations, but then we're also trained in anatomy and physiology and psychology. So we wear a lot of hats already. So now if we're thinking about a hand injury, there's a hand injury that walks through your door, and often that is occasionally accompanied by a referral from a doctor, and what it just says is zone 5 extensor tendon laceration, or right distal radius fracture, or sepsis or septic hand. However, when the patient sits in front of you, this is what they tell you. I can't tie my pants, or I struggle to cut the butternut or to peel the potatoes, or I'm struggling to lift the bucket of water so that I can take it back to where I live. I really am worried that I can't get back to work and feed my children. I'm the only one that earns money in the house. Or it's really difficult for me to wring out the washing because I can't get that grip, or it's really painful. So I think it's important for us to see patients speak in functional impact. They don't speak in medical jargon. You very rarely have someone sitting in front of you saying, I have a zone 5 extensor tendon injury, or my EDC has been lacerated and repaired. They are telling you what they're experiencing. So the impact of a hand injury is multidimensional. It impacts essentially the person's ability to participate in their meaningful occupations. So it's not only work, it's their function, it's in their independence, it's their ability to do leisure things, it's their relationships. They can't hold hands with someone, maybe struggle to be intimate with someone. They have now self-esteem issues potentially if there has been a maimed hand, or their body image has now been altered. So all of these things are not only physical, there's generally an occupational performance and engagement difficulty, which is again the core concern of an OT. So traditionally, hand therapy, if you read a whole bunch of articles in the older textbooks, it's always based in a very medical model. Its focus is biomechanical or biomedical, whatever word you want to use. But the main aim is to reduce impairment. So they look at the person as a whole bunch of little parts, and then they focus just on the hand, because the hand is what's, what's been injured. Which then is now reinforcing the diagnosis. So it's saying your little finger extensor tendon injury is way more important than who you are, or who you are and what you need to do. So the impact of the function and the interaction on the environment is sometimes often lost. So we don't have that occupational focus if we're looking at it from a very traditional hand therapy point of view. But they found that the degree of physical impairment doesn't always equal the functional difficulties. So I don't know if you've had a patient, sometimes you have someone that's had an extensive traumatic hand injury, but they kind of just get on with it. They're pretty functional, they do what they need to do. And then you might have someone with a PIP dislocation, and they can't do anything. They report their disability as sky high for that period of time. So things like pain and range of motion and strength aren't always correlated, or they don't always equal the patient's satisfaction in what they can do, which means we have to not only consider your pain and your range of motion and your sensation and your strength. We need to start looking or widening our focus to something more, because remember, we're the experts at function. So an OT as a hand therapist, we have training in anatomy, we have training in physiology, in human movement. We are experts at facilitating function, and we're very uniquely placed to now bring all these areas all into one, so that we can consider the physical, the contextual, the psychological aspects of an injury, and have a look really at what the occupational impact is. So this brings me to occupation-based hand therapy. It is described as an approach for treating hand therapies that aligns with our core OT philosophy. So it looks at the person, not just the hand, and also the impact that that person's hand injury has on their needs, their environment, their participation. One of the key aspects, it's very collaborative. So it's not I'm going to tell you to do this and this and this exercise. It's a collaborative two-way process that is person-centered and holistic. And the most important, I actually should have underlined that, is that occupation is central. It's central in and to intervention, because the main goal of occupation-based hand therapy is to facilitate the performance and engagement in the person's chosen meaningful occupations. So just to give you an idea, so if we're looking at a biomedical approach, this is, I don't know if you remember the ICF diagram. A biomedical approach is that red circle. So it really focuses on the health condition and then the body functions and structure. An occupation-based approach is now including all of it. So it's looking at participation, it's looking at the person's personal factors, the environmental factors, the context that they're living in. So it's not taking away just the condition and the body functions and structures. It's including a whole lot more, which means our focus needs to really open up quite a lot. I'm not going to go through this just because it's going to take some time, but it is in your handout. But it really gives you kind of a nice comparison between a biomedical and an occupation-based approach, which just again highlights focusing on the context, the environment, and specifically occupations. So benefits, there's a whole load of journal articles. I have referenced some at the end, but I'm not going to go through them all. But there's really a big body of research coming out that shows that there's positive outcomes towards OBHT. It's definitely a holistic approach. And because you're incorporating the person's occupations that's meaningful to them, not to you, patients are a lot more invested in therapy. They have true to life scenarios, which means you get a more accurate idea of where they're at in terms of functioning in their environment. I mean, it's also really meaningful. And then my favorite is that it demonstrates the uniqueness of OT. I think sometimes OTs that are situated in big hospitals or orthopedic clinics where they practice their hand therapy intervention, sometimes they lose a little bit of the OT spice. And this really helps to kind of highlight that and also promote us as a profession. So how do I use OBHT? First things first is you have to shift your focus. You have got to start looking more at the person sitting in front of you instead of the distal radius fracture sitting in front of you or the metacarpal fracture sitting in front of you. Don't get too caught up with the diagnosis, because sometimes we get really overwhelmed and we think, oh my gosh, it's a dog bite, I don't know what to do, or it's a crash injury, I'm not sure how to do this. You're going to have a look at the whole person and consider the injury in conjunction with their performance components. And you do this throughout the whole OT process. So I'm just going to quickly break that down and simplify it. But you generally are putting two hats on. You're wearing your biomechanical hat. That, remember, we're not taking that away. That is still super important. So we still are looking at pain and range of motion and strength, but we're adding to that our occupational hat, being like, what does this person need to do? How is this impacting their ability to do what they need to do? So we're wearing both. So you have this dual focus where you merge both approaches, almost they overlap each other, which means you don't really stop when the physical outcomes have been met. So if you're getting a full range of motion and you're happy with their movement, you don't discharge them. You're still looking at what else are they struggling with, because someone can have full range of motion but still not be able to do what they need to do. This also then requires us to understand occupation so that we can start to integrate it. So in order to understand the occupation, we need to have an understanding of them as an occupational being. This often happens basically throughout the whole process, but really through the interview and assessment. And then you're going to keep looking at activity and participation. So activity analysis is really important. Understanding their physical components as well as understanding the injury. So there's a lot of things that we need to take in and synthesize and before we kind of take it out to the person. So if we have a look at the OT process with an occupational lens, assessment is the very, very best time to start with incorporating participation. And sometimes this just means talking about it. You want to gain an understanding of who the person is. There's a study that they did where they had a look at patient satisfaction after distal radius fractures when someone in the trauma unit started speaking about occupation and the engagement and how to do things, and then they took the other cohort where they didn't do that. And the people were so much more satisfied with their outcomes just because they kind of knew what to expect. So even talking about it in your assessment is so important. You need to collaborate with your clients. Just as I don't know what's important for you, how you like to spend your morning before you get up, getting ready for work. You don't know what's important for me, what I like to do after work, which means we aren't experts in the person and their occupations, which means they need to be telling us what's important to them. Another really important thing to do is to get to know your context and the culture that you work in. I'm sure a lot of you are kind of spread throughout the country and maybe even abroad. And along with that comes a lot of different cultures, a lot of different beliefs, a lot of different potentially factories and working environments. So the more you familiarize yourself of where you're at, the better you can start to anticipate what you're going to need to work on. For instance, I work in a practice that's very close to a harbor, so we see a lot of patients that working on ships and get injured. So I already know a lot about the fishing industry and what one of those patients that needs to get back onto a fishing boat requires in terms of their grip strength and their endurance and cold tolerance and things like that. So I've added these are pretty much my favorite questions to ask, because sometimes when a patient is sitting in front of us and we ask them, what do you do? They tend to tell us their job. They'd say, I'm a secretary, or I am a painter or a bricklayer. Whereas you say, how do you spend your time? They start to add a lot more information. Another cool one that I found gives me a lot of information is asking them what brings you here, because now you're already starting to figure out what they think you're going to do and who you are, and it also gives you an indication of what they think is wrong and the kind of help and intervention that they need. Something like tell me about your daily routine from when you wake up to when you go to bed generally incorporates a whole lot more than just what they do at work. What do you do when you're not working? For those people that tend to just focus on their job, then you start to kind of get the others. And sometimes you get the most radical things, like I have a spaza shop where I sell a lot of vegetables that I grow in my garden, or I'm a mother, or I part-time in a philharmonic orchestra. So you start to get a lot more information about what's important to that person. Generally, I feel like probably you'll get more important information than what you do if you just ask them what they do for work. Another one is, what are you unable to do now that you could do before the injury? Start to give you an indication of the impact. Something like, what do you find most frustrating? And then the last one, have you ever had an injury like this before? This gives you a lot of information about their beliefs about the experience, the pain that they're experiencing, their fears, how they picture an injury in their head and what they think is going to happen. So you start to really build a better understanding of who's sitting in front of you. Okay, so your assessment generally involves your interview, where you're going to have a look at those factors. Patient-rated outcome measures are also really, really nice, a useful tool to use to establish a functional status. The DASH has got a couple of South African language translations, which are useful. The COPM is super cool because it's basically the patient telling you, prioritizing for you what's important to them, and it helps to reflect these cultural differences. And then you also have your specific component assessments, which we all know, so I'm not going to go through them. Okay, so once you're now starting to figure out who this person is in front of you, and you already know what's wrong with them in terms of their hand condition, now you start to synthesize and you merge those two focuses together. And I find the best question to keep in the back of your mind is, how do I get this person doing what is important to them now, maybe next week, maybe in 6 weeks? What do I need to stop them from doing now, next week, in 6 weeks? What do we modify? What do we need to change? Can I provide any assistance to get the person to do what is important to them? These things evolve throughout. So often acutely, you're not going to be getting them to go and water the garden carrying big buckets. You might have to provide or think about or brainstorm or some other compensatory or assistive ways to do that. But maybe at the 8-week mark or 10-week mark, or when you see them again, things might be a bit different. So as long as you're keeping that at the back of your mind of, how do I get this person doing what's important to them, it helps to keep you kind of focused in terms of that occupational lens. So when it comes to intervention, again, occupation is central. So you're having a look at occupation as a means and occupation as an end. Just reminding those that haven't been in academia for a long time, or it's a long time since you qualified. Occupation as a means is basically using occupation in your treatment as the modality to get to the goals and the components that you want to work on. Whereas occupation as an end is basically your end goals. So the performance in that specific occupation is what you're aiming for. It's your end in treatment. I'm going to just go through a couple of examples. So this guy, he worked in the film industry. He was using an angle grinder. He sustained a couple of amputations of his fingers and then also some flexor tendon injuries, ended up with a lot of stiffness. But actually that wasn't super important to him. His main passion in life is he was a bass guitarist for a metal band, and all he wanted to do was play his guitar again, because for him it was therapy in a sense. So the picture on the left, you can see with the little pink, we made a little plectrum, but it was really important for him to be able to hold the plectrum comfortably and in the right position so that he could play. But he didn't have the right range of motion in his index finger to do that. So you can see the difference between the index finger PIP on his unaffected hand and then his affected hand. The goal is to get him to hold the plectrum as he wants, which means we need to improve his range of motion of his index finger, his PIP. So I'm using biomechanical techniques such as sustained passive stretch to improve his range of motion, using a flexion strap so that he can then hold his plectrum in a comfortable way. So that's an example of occupation as an end. If we look at this is just another quick example. I had a musician come in. She was playing a French horn, and that it has to rest onto your thumb, causing her incredible amounts of pain. She ended up having to take a couple of weeks off, and it was her main income. So came to us, we made her a splint to support her thumb in a position that allowed her to hold the horn. It wasn't a functional position. She couldn't use it for anything else. It was specifically for her musical instrument. Happy days. And she was able to go back to performing pretty much pain-free. If we look at occupation as a means, now we're starting to use occupation as our modality, our treatment modality. This lovely lady, she is diabetic, and she had multiple sepsis and multiple debridements from hand sepsis, which then resulted in chronic swelling, chronic edema, fibrosis, and global stiffness. It was her passion to go out to dinner parties and go out and eat with her friends at restaurants. However, she was unable to use a knife and fork. So we were using the occupation of eating and socializing as a treatment modality throughout the whole process for her. So initially we made a little PG glove because she was nervous of all the scars, and we started doing things like going out for pizza, so handheld food. Eventually, when we started getting her range a little bit better, you can see the bottom picture, started building up her grips. That's not specifically hers, but started building up her grips so that she was able to manipulate a fork. And then eventually, more towards the end, she's regained full range of motion, able to hold a fork, still getting back to going out with her friends. So using the occupation of eating throughout, but modifying throughout. I'm just going to go through a couple of others, just incorporating patients' chosen function in their sessions. I'm not going to give you the whole spiel, but it's just to almost get your creative juices flowing. This is back to the same guy who had the multiple amputations. He was really struggling to hold his phone, so we ended up making him little thermoplastic fingers, or prosthetic fingers, I suppose you could call them, so that he could grip his phone in order to text. Super happy, and then he actually started making some himself, and able to hold it really comfortably. This gentleman, again, another septic hand, so ended up in a ray amputation, which you can see has a lot of stiffness, a lot of swelling, reduced range of motion. For this gentleman, again, all he wanted to do was hold a knife and fork comfortably and feed himself, because he didn't want his daughters to feed himself. So what do? We're using occupation of eating throughout, working on his active and passive range of motion. So still incorporating these biomechanical principles as improving active range and improving passive range and improving grip strength and in-hand manipulation. So we're not throwing out that out the door, but we're having an occupational focus or lens in why we're doing what we are doing. Made him a PG glove, and eventually he was able to quite comfortably hold a fork. This chap just wanted to have some wrist stability while he was going back to cycling. He'd had a massive wrist injury, lots of ligament damage and a bit of instability. Got him to bring his bike in to make a splint on the bike. It's not something he can use anywhere else, but it's just on the bike for when he goes back to cycling, because that for him was the most important thing in his life. This guy over here, you can see a massive crash injury. He got his hands caught in a machine that sustained multiple fractures, which ended up in multiple amputations. All this patient has left is essentially his index finger up to his PIP, and his thumb, which you can see from all the KYs, was going to be quite stiff. And the reason I included this case study was also just to remind you to check your expectations. We know that hand is going to be compromised in terms of function. We know that ultimately the most functional thing that this hand particularly can do is index finger MCP flexion and thumb adduction flexion, so almost aiming to a pinch. So it's important for you to try and focus or kind of know your limits and anticipate what are we aiming for, just to guide your intervention. So that's kind of what he looked like when he got here, when he got to us the first day, and by the end of it, he was able to go back to work on his machines, using his hand as a support, really getting a nice strong grip. Last one, I think it is. This chap was a C5, C6 spinal cord injury that had sustained a spinal cord injury, I think a decade ago. He was a digital illustrator, struggling to hold his stylus so that he could write on his, illustrate on his iPad. And that was how he was doing it. He was just taking a little elastic band and popping it in. Obviously getting some pressure sores, super uncomfortable. So he was like, I really need to do this for my job. Can you help me? I didn't then go into, let's see if we can get your range of motion a bit better, or let's see if we can strengthen up some muscles in order to help you. He'd had this condition for a decade already. What was important for him was be able to do his job. So we essentially, this is just how he got it on. So essentially just made a couple of different options for him in order to stabilize his stylus. So you probably have a couple of questions, because I know I'm speaking pretty broadly, but what if you get a late referral and the patient's super stiff? Or what if you get a referral on day one and it's a tendon repair and you have to follow the protocol that the doctor told you, or that's the protocol of the hospital? Or what if you get a patient that comes to you with open wounds and you can see their tendons, and now do you do something? Don't you? Do you wait? Or what if you have a patient that actually wants to be injured because maybe they're going to get compensation? All of these challenges are very real, and they are things that we tend to deal with on a daily basis. My advice is know your scope of practice. When you know your scope of practice as an OT or as whatever profession you are, you kind of know where your boundaries are. So then you know what you can focus and maximize within that scope of practice. That then leads on to know your areas where you need to expand your own knowledge. Read up on conditions. Conditions don't change. A distal radius fracture has been a distal radius fracture for the last hundreds and hundreds of years. So familiarize yourself with them. Become comfortable with what they look like, what they feel like, how they heal, things that you may anticipate happening from them. And then remember, if you get an acute patient, often you might need to have a bit of a biomechanical focus initially. Again, occupation as an end will always become your lens, and you can always incorporate occupation throughout that process. Incorporate your goals into daily routine. So if you're wanting the patient to work on finger flexion or finger range of motion and flexion, Do it as in, like, let's try and see if you can hold your toothbrush while you brush your teeth, or let's see if you can do this 4 times a day when you drive to try and get your fingers to curl all the way around your steering wheel. Remember, patients are motivated by what's important to them. So as soon as you find what they want to do, you're going to get a lot more success and satisfaction both ways, for you and for the patients. So your occupational profile is so important. Get to know them. This is pretty much just what I said. And then again, like I said earlier on, become aware of the occupations that are in your context. If you can, build an occupational kit that matches with them. So I encourage you, start a list of occupations that patients tell you about when they sit in front of you. If you're finding out a lot of them need to wash their clothes by hand, write that down. Start to think, what do I need to do that? What do I need in terms of grip strength, of movement, of carrying buckets and water? I know a lot of this does sometimes become overwhelming, so just dial it back, go back to basics. Ask yourself, what does this patient need to do, and how can I help them do that? And then the last one is practice activity analysis. It really is key in order to be able to bring all of this into your treatment. Okay.
Hey, thank you, Ilande. That was a great presentation. Please remember, if you have any questions, you can post them in the chat box. And for now, I'm going to introduce our next speaker. So Dr. Jennie McAdam is an OT lecturer and an expert generalist. She has extensive experience in the development, delivery, and management of occupational therapy and rehabilitation services in the public and private sectors in South Africa, including provision of services in rural contexts. Her PhD looked at developing and validating an assessment battery specific to rural settings in South Africa. Jennie continues to advocate at a global level for rural settings and rural occupations to be integrated into our theory and practice. She is passionate about occupational justice for rural residents, as well as environmental sustainability, which she sees as a critical element of responsive occupational therapy practice. She is unfortunately not well enough today to give us a live presentation, but she has pre-recorded her presentation for us, and she will be available afterwards to answer your questions. Thank you.
Good evening to everyone. Thank you firstly to Nicola, Kirsty and Erica for the invitation to present as part of the Open Hand Therapy Initiative. I'm really looking forward to being able to share some insights together with my colleague Ilande Vorster. So Ilande has already impressed on us the importance of assessing the occupational profile and becoming aware of the occupations that are in our specific contexts. I'm hoping to be able to provide some food for thought arising from my doctoral study regarding building what she describes as an occupational kit for South African rural contexts. And before I continue, I would just like to express my grateful acknowledgement of Dr. Denise Franson and Prof. Dalian Castellane, who were my PhD supervisors during the study that I'm going to discuss. But before I get started, a couple of quick disclaimers. Firstly, for those of you who know me, I'm sure you'll agree that I'm not a hands therapist by any stretch of the imagination. However, I do hope to be able to share some of my expertise and experience in rural public health, community-based OT, activity analysis, and then their application to this hand therapy platform. Secondly, I'd like to clarify that the activity analysis that I'm going to be describing, which arose from my doctoral study, focused particularly on manual handling as defined in the table on the slide. I will, however, attempt to apply these learnings to hand therapy. So with those disclaimers out of the way, please allow me to jump into the background of my study. Having lived and worked in outlying areas for most of my OT career, I was always aware of the heavy loads that rural dwellers handle manually as part of their everyday tasks or activities of daily living. And So when I started practicing in the medico-legal field, I realized again that independence in these ADLs is viewed as a prerequisite of workability. And so for me, the assessment and management of rural clients became problematic, as existing instruments don't consider the unique occupational demands of these settings. My study was therefore to investigate activities of daily living typical of rural settings and to develop a contextual ADL assessment instrument. So the title of my PhD study was The Development and Validation of the Rural ADL Manual Handling Sort. The first phase of the study took place in Limpopo province and allowed for collection of rich data regarding the contextual forms of activities of daily living. This information was gathered through discussion groups with community care workers as well as home visits and underpinned the instrument development design of the study. Activity analysis was then applied in the analysis of the data, and this showed that the occupational forms or methods of doing the activities of daily living were adapted to the contextual lack of resources. A selection of the study results are shown on this slide. None of the participants were found to have piped water into their homes or yards, but rather had to collect water from communal sources. Typically, the participants collected water from a tap in a street nearby to their homestead, from a single source for the entire village, or from a river. And similarly, all participants in the study collected fuel wood from surrounding areas for cooking and heating water. The data collected during the home visits and discussion groups showed that the types and forms of numerous basic and instrumental activities of daily living are unique within a rural, resource-scarce context. So, activity analysis is a core component of occupational therapy practice and is essential to the clinical reasoning process that practitioners use to plan and implement care. By applying activity analysis to the data, it became clear that household access to the amenities of water and fuel were the greatest determinants, and that the absence of these amenities results in rural dwellers needing to engage in very physically demanding occupations. So what exactly do we mean when we talk about activity analysis? Occupational therapists make use of activity analysis to describe the various aspects of occupations, such as the performance skills that are involved in the occupation, the required equipment and materials, and the physical, psychological, and environmental demands of the occupation. And as OTs, we regard performance skills as being discrete units of occupational performance, which, when we link them together, they form the task as a whole. So going back to the activity analysis within my study, the absence of indoor plumbing and limited access to electricity means that the way activities such as bathing, cooking, and doing laundry are done in a rural, less resourced context differs markedly from urban settings. Instead of, for example, using a built-in bath or shower, an electric stove, and a washing machine, which might be typical of many Western settings, water and fuel wood first need to be collected before these activities of daily living can even be tackled. The availability of adequate sources of water and energy are then a prerequisite to the completion of a number of these activities of daily living. For example, one needs hot water for bathing, washing dishes, or doing laundry. Water then first has to be collected from the available source, such as the tap in the adjacent street or the communal village tank. And fuel wood also has to be collected so that the water can be heated on an outdoor fireplace in the yard. So this certainly involves at least one household member walking into unpopulated areas adjacent to their villages to chop down a tree and then carry the wood back to their homestead. And then the fuel wood is obviously used to build a fire to heat the water. So we can see that water and fuel wood collection occupations involve both significant time and physical demands. The next few slides are going to illustrate how activity analysis was used in the study to examine these activities of daily living within this rural, less resourced context. So on this slide, the occupation of bathing or washing one's body is presented in a bit more detail. Each step of the occupation is described, and one can see how the water first has to be collected from a source outside of the home before the bathing occupation can even commence. Using the activity analysis of bathing as an example then, the lack of piped water available in households meant that community members needed to collect water from an outside source before beginning to take a bath. This typically involved pushing empty 25-litre plastic water containers in a wheelbarrow to the village water source, waiting in the queue before filling the water containers, and then pushing the wheelbarrow loaded with between 1 and 4 full containers back to the homestead. Of course, the quantity of water needed to bath for an average family frequently involves more than one trip to the water source, depending on how many 25-litre water containers the particular household had and the particular household member was capable of transporting at a time. As I've already said, fuel wood then also had to be collected from the surrounding forest in order for the water to be heated on the fire. And collection of fuel wood is typically done by the same household member who's already walking extensive distances to collect water. So they walk to find an available tree, chop down the tree, and then carry the load of chopped fuel wood back to the homestead on their head. Bathing could then only commence once an adequate amount of water and fuel wood had been collected. The community care workers in the study described the following typical method of bathing, which involved filling a plastic basin, colloquially known as either a skottel or a wasbak, with warm water from the outdoor fireplace, and then carrying it into the bedroom. The individual would then conduct the equivalent of a bed bath by dipping a face cloth into the water, applying the soap, and then washing the various body parts clean. The face cloth would then be dipped into the clean water so that any remaining soap could be wiped off the clean body parts. The dirty water in the basin was then disposed of by carrying it outside. This could either be disposed of in an outdoor traditional toilet or perhaps be thrown out onto the ground in the yard. The dirty bathwater was disposed of by scooping it into a bucket and then pouring it into the outdoor traditional toilet or throwing it out into the ground one bucketful at a time. So while I've already gone into quite a lot of detail about an example of activity analysis, this slide shows how activity analysis was taken a step further and was used in the study to identify items for the RAMS instrument that was developed later in the study. Each step of the occupation, as well as the required equipment and materials, were identified, and then analyzed in terms of the 3 manual handling domains indicated in the table. The lift, carry, and push components in each step of the ADL occupations were described and then color-coded to allow for easy identification of the manual handling categories pertinent to each respective step. In line with the theory, the lifting domain was further subdivided into different components, namely the floor to knuckle lift, the knuckle to shoulder lift, and the shoulder to overhead lift. So for the purposes of this evening's presentation, I've gone a step further and tried to capture the hand function component of the water collection occupation. One can see from the photographs on the slide that pushing a wheelbarrow loaded with full water containers involves bilateral hand function, and that a hook grasp is typically used to hold the wheelbarrow handles. Of note for me is the significant force needed to push a wheelbarrow loaded with 50 kilograms of water, and of course the great distances that rural dwellers typically push such loads. Similarly, in this slide, one can see how water containers are carried by many rural dwellers, particularly where a family, for example, may not have access to a wheelbarrow. Again, we can see that a hook grasp is used to carry the 25 kilograms of water in the right hand, but also note that this young lady is carrying a further 50 kilograms of water in her left arm and hand. So she's transporting a total of 75 kilograms of water, having waited at this water collection point. And then to complete the activity analysis exercise, the cumulative extent of the water collection occupation was examined in more detail. One can see that even using fairly conservative estimates of daily water requirements, most rural dwellers need to make multiple trips daily to collect water. So the World Health Organization estimates that each individual requires at least 50 to 75 liters of water per person per day to complete all of their domestic tasks, as well as for basic survival. And so for the average sized family or household within Limpopo, this amounts to at least 180 liters of water that needs to be collected per day. So the number of daily trips then tends to depend on the equipment available to each particular household, as well as how many water containers they can carry or push per trip. The table on the right-hand side of the slide then shows how using a wheelbarrow, carrying either 2 or 3 full 25-liter water containers, how this pans out in terms of the number of trips that one member of each household would need to make each day. Lastly then, before I step off this relatively deep dive into activity analysis, a quick look at how prevalent these rural occupations actually are. Globally, almost a quarter of the world's population do not have adequate access to potable water, and the extent of this challenge is enshrined in the 6th Sustainable Development Goal, which focuses on improving access to clean water and sanitation. Similarly, the household use of fuel wood is still fairly common worldwide. In South Africa in particular, there really have been numerous significant improvements in access to water and electricity since our democracy in 1994. However, challenges nonetheless remain, and one can see from a number of recent events that these challenges are also not particularly restricted to rural areas alone. I would also like to just comment that I'm mindful that a number of the attendees this evening are from outside of South Africa. So I'm particularly curious to hear about the applicability of this evening's discussion in your contexts. In conclusion then, I hope that this presentation has added to the conversation about occupation-based hand therapy, and particularly in scarce resource contexts. And I'd like to leave you with some of my thoughts for your consideration. First of all, I think it's really important to always check one's client's household amenities, because this will give a really good idea of the types and the forms of occupations that your client is performing as part of their activities of daily living. Flowing from this, remember to check which types of household equipment your client then particularly has, such as basins, water containers, or water drums. And I also think it's a very good idea to have a number of these items available within your clinics. Furthermore, I think it's important then to clarify which particular role or roles your client performs in terms of these typically rural occupations. For example, is your client the member of the family who normally collects water or fuel wood for the household? And is this something that can potentially be delegated for the duration of the healing process after the hand injury? From my perspective, I think it would also be advisable to think carefully about the timing of your client's return to a number of these contextual occupations. I think that realistic infection control measures need to be taken into account, considering your client's access to water and fuel to heat the water. And I think considering the extremely high physical demands of many of these occupations, returning to these occupations too soon after hand injury could further complicate and compound the situation. I think that also one might need to think about whether these rural occupations are actually contributing to the load or the presentation of hand injuries within your particular context. Certainly, anecdotally from my research, I was made aware that snake bites are a fairly common hazard when collecting water and fuel wood. And as I have already said, I think that the extreme physical demands of these occupations are very likely to result in injuries as a result of repetitive strain with these extreme loads. That said, I would like to once again thank everyone for the opportunity to participate in this platform, and I'm thoroughly looking forward to your comments and questions. I've added some references to these last two slides. Thank you.
Thank you for your great presentation. We don't have so many questions, but we can talk about the ones that have come up. So Ilande, a question for you. There's someone asking about a 70-year-old man who's a patient of hers who has weakness and poor range of motion of his upper limbs, and he wants to be able to eat and drink by himself and to fasten his trousers again. So what tips would you give this therapist on how to help her patients?
Yeah, I did see, I saw the question, and I saw Kirsty had kind of already answered specifically exactly what I was going to answer. And I think perhaps it's not necessarily always trying to remediate or trying to fix the problem, because maybe we're not quite sure what the actual cause of the weakness is. So perhaps it's worth rather having a look at what he needs to do and how to and how to get him to do that. So I see a few people have suggested compensatory things like giving him loops to help pull up the pants, perhaps giving him some or advising on some cups with some handles so that he's able to start to rather functionally participate instead of trying to get the muscles a lot stronger. This being said, it's purely because we're not quite sure what the cause is of the injury, of the weakness.
Thank you very much. And then, Jenny, a question for you. So we do have some physiotherapists attending the webinar tonight. How would you suggest that they apply what they've learned today?
Thanks very much for the question, and it's great always to be part of a multidisciplinary team discussion. I think that most physiotherapists that I've ever encountered are very familiar with and enjoy using the ICF, and as I think Ilande was talking about earlier, I think that awareness of rural occupations is important for all members of the team. And I think when it comes to particular strengthening, at the extreme ends of strength, if I can put it that way, I would love to hear from the physiotherapists on the platform, but I would imagine that there's a huge particular role there, bearing in mind the massive physical demands that I have outlined in some of these occupations. I'll leave it at that for now. Thanks.
And Ilande, how would you incorporate occupation-based therapy when there's limited time and resources, for example, in a busy inpatient facility?
Always the trickiest question. A lot of the occupation-based research generally actually focuses on barriers to occupation-based hand therapy. And these are sometimes, I'm not taking the cop-out way, but these are real issues. Most of the literature has said that time is a factor, patient load is a factor. So I feel like just dialing it back, and if you can kind of even just focus on one thing that's important to the person, it's always a win. If that is in order to protect them in a splint, if you're seeing them early on in the injury, focus on that one thing. If they're coming down late, it's a late presentation, they're super stiff, you're not going to get all range of motion and everything sorted out immediately in that one session. You've got 10 minutes with them. Ask them what they're struggling with and see how you can apply your skills through activity analysis and compensatory to get there.
Okay, and I think that can bring our webinar to an end for this evening. Okay, so thank you all for joining us this evening, and thank you to Ilande and Jenny for your great presentations. Our next open hand webinar will be on the 4th of March, and the topic will be how to work with what you have, a hand therapy veteran's low-cost tips and tricks. We will open registrations for the webinar soon. And to keep up to date on our webinars, you can follow us on Instagram and Facebook. You can also watch our past webinars on our YouTube channel. You can sign up to our mailing list by scanning the QR code to access the sign-up form. So we send out a monthly newsletter that has a link to the next webinar and also the latest updates on the Open Hand Therapy Initiative. So spread the word, and we hope to see you all there.